Hi, Dr. Kevin Windisch from Sparks Pediatric and Adolescent Medicine here. Welcome to our video series for students. Before we get going today, again, this is how you can find us. This is my address. Phone number 775-359-7111, and our Facebook page. Feel free to like us on Facebook. We'd love to see you there. Please remember that this series is not intended to replace visits to your doctor's office or, for that matter, professional educational training. But if we can be of assistance, or if you'd like to schedule a rotation with us, please give us a call. We would love to have you here. Today, what we want to talk about is diagnosis and management of a subject that's near and dear to my heart, and it's something that I see treated locally inappropriately way too often, and that is otitis media. And again, today's discussion is really for students. So for parents, I apologize. I may be speaking over your head. That's what I've got other videos on ear infections for parents that certainly anybody can watch, but may answer your questions a little bit better than this video. And what I want to reference today is a paper called sorry, that's not an A, not an I, that's an E. So the article we want to reference is Diagnosis and Management of Otitis Media from the journal Pediatrics. Now realize Pediatrics, for those of you who are students and are kind of new to this, Pediatrics and Journal of Pediatrics are not the same thing. They're both excellent journals, but Pediatrics is the one published by the American Academy of Pediatrics. That's where you're going to find AAP position statements, and that's what this particular article here is. Diagnosis and Management of Otitis Media is a position statement from the American Academy of Pediatrics. This is the 2004 statement. Okay, and then realize that the guidelines published here are very similar to the guidelines published on judicious use of antibiotics in otitis media from 1998 in the same journal. So, although this is the article that I really want to talk about, and that for my students currently I'm having them read when they rotate with me, the article on judicious use of antibiotics is still valuable and really hasn't lost its validity. So what I want to look at next is what causes otitis media. What are the organisms that cause otitis media? Well, to be truly honest, a good portion of them are viral. The problem is you can't distinguish between viral OMs and bacterial OMs just by looking at the ear. So we wind up treating. In the cases that are bacterial, there are three major players. There is Haemophilus, influenza, For those of you who are uninitiated, and of course if we're going to do this right, let's do this right. For the uninitiated, please realize this is the bacterium H. flu, not the virus influenza. And for those of you who are familiar with H. flu, this is non-typable. Whoops. Where'd everything go? As opposed to its nastier cousin, Haemophilus influenza type B. Hib we vaccinate against, but realize that the vaccine for H. flu, which is against the type B strain, is against a capsule that goes, a polysaccharide capsule. Well, let's see. So if this is the bacterium, Hib then makes a polysaccharide capsule that goes around it that allows it to become invasive. This is why it's the bad actor that it is. We make our vaccine against this capsule. The problem is, and so we're able to destroy Hib and kill it. The problem we run into is the Haemophilus influenza involved in otitis media doesn't make this capsule. And as such, the antibodies don't have anything to stick to. So they don't, it's not helpful. It doesn't alter the course or natural history of Haemophilus influenza otitis media. The next bug is Moraxella. Cataralis, or MCAT. And then the last one is Streptococcus pneumoniae. And again, just in the interest of accuracy, we'll stick with scientific nomenclature here. Okay. Now, why do we care the specific bugs that are in the ear? Well, my approach that I teach my students to treating infectious disease is that you need to know what bugs cause a specific infectious disease, and then you target them appropriately with antibiotics, depending on the sensitivity or the known sensitivity patterns of the bugs involved, and then considering volume of distribution and penetration into the tissue that's affected. Okay, so but the first thing you have to know are the bugs. That's as opposed to, well, drug X works well for ears and drug Y works well for skin, but the two don't interchange. Well, that doesn't make sense. And when you think like that and you have an unusual organism infecting either place, you're not going to be able to treat it. Using this approach, you will be able to tailor your treatment and cure the infection that is at hand. All right, so what are their mechanisms then of resistance to antibiotics? Well, H. flu is a beta-lactamase producer, as is MCAT. Strep pneumo has a different approach, and that is alterations in penicillin binding proteins. So, how do we treat these infections? Well, first and foremost, following the American Academy of Pediatrics position statement, most OMs don't need to be treated. So when a kid over 2 years of age who's afebrile and non-toxic, you can do watchful waiting for 48 hours. Don't forget to treat with something for pain. So antipyrine and benzocaine, Otic. Plus Tylenol or Motrin for pain. Okay. In cases where you are going to treat, the recommended first-line agent is amoxicillin. How much amoxicillin? Well, standard dose of amoxicillin is 20 to 40 mg per kilo. Oops, well, I'm just all over the page here. Per day. Okay, however, when you are dealing with patients who are infected with intermediate resistant Streptococcus pneumoniae, which in the modern world represents the vast majority of isolates, that's not going to be effective. So you need 80 to 90 mg per kilo per day. So we're going to put a star here, and we're just going to line this out because that's really kind of the old-fashioned dose. Can be given or should be given in divided doses. You realistically, in the modern world, if you're going with 90 per kilo, there's a different position statement that recommends that you can go at 90 per kilo and divide it twice a day. So BID. That will cover your strep pneumo, and it'll cover your non-beta lactamase producing MCAT and H flu. This represents roughly a third of ear infections. These represent roughly 2/3 of ear infections, but only have about a 20% and 20% resistance pattern. So that's 20% of 60%, which represents then only about 12% of infections. Hence the approximate 90% cure rate of amoxicillin. All right, now what do you do if somebody fails treatment with high-dose amoxicillin? Well, then we need to account for the beta-lactamase production. And there are really two ways to do that. We can add a beta-lactamase inhibitor, clavulanic acid. So amoxicillin plus clavulanic acid equals augmentin. Or we can use a beta-lactamase resistant cephalosporin. So that would be cefdinir, which is Omnicef, or cefpodoxime, which is Vantin, or cefixime, which is Suprax. Suprax isn't always so easy to get a hold of. So, well, I don't see it written a whole lot because you can't always find it for your patients. That now treats most ear infections. All right, what do you do if a patient is allergic to amoxicillin? Well, then amox plus clavulanic acid is not a good choice. But you can definitely jump straight to ceftonir or cefpodoxime as your second line treatment. Now, this will get you flags in your electronic prescribing system, and the pharmacist will call you as well. This is because in the old days when the first cephalosporin was developed, Ceftin, or what was it called? Keflin, there was about a 25% concordance rate in allergy between amoxicillin and Keflin. Keflin had a long tail on it that looked an awful lot to the immune system like amoxicillin, and so there was a cross-allergic pattern. However, rates of cross-allergy for modern first-generation cephalosporins, Ceftriaxone, are less than 2%. And for the third and fourth generation cephalosporins, which we're using for treatment of otitis media, even less. Put another way, they don't resemble, although they have beta-lactam rings. And for those of you who aren't sure what a beta-lactam ring looks like this. In the molecule, it's almost a square ring. There's a lot of energy stored in this ring, and when this ring splits open, it creates peroxides that then destroy the cell wall of the organism in question. They both have beta-lactam rings, but your IgE is not typically directed against the beta-lactam ring, it's directed against the tail. So as long as your tail was different, you're okay. Now the other thing that this article gets into is the role of everybody's favorite antibiotic in this world, Zithromax. What is its role in treatment of otitis media? And the answer is it's relegated to last line. Azithromycin does not have good penetration into the middle ear space. It is cheap, it is widely available, it has good GI tolerance, but with poor penetration into the middle ear space and short courses, especially if you use the 10 per kilo, 5 milligram per kilo per day therapy that is in the form of pills known as a Z-Pak, you have a roughly 20% failure rate. Especially if you're doing just a 5-day course. Cure rates can be a little bit better if you use 10 milligrams per kilogram Q-day for 5 days or 10 milligrams per kilogram per day for 10 days. However, you still have a very high failure rate. To that end, it's generalizably not recognized as a valid option. If you have a patient that is allergic to both clavulanic or to both amoxicillin or to all penicillins and to cephalosporins, and you want to go with a macrolide, then your better choice is EES or EES, whoops, a little too many lines there for an E, plus sulfamethoxazole in the form of pediazole, or clarithromycin. In its liquid form, the issue with clarithromycin is that it tends to be pretty gritty, so you got to make sure it's shaken very well. If there's better penetration in the middle ear space with clarithromycin and a better cure rate, but it still has a high failure rate. Clarithromycin's bigger role is in treating resistant otitis media that has failed therapy with both first-line amoxicillin and second-line treatment. Because once in a while you have something that's got just weird resistance patterns, Both of these are beta-lactams, and so you need something that's not a beta-lactam that just completely avoids the same mechanism of action. And clarithromycin, because it disrupts ribosomes in the bacteria instead, is useful because a completely unrelated mechanism of action. What about the role of injectable cephalosporins, Rocephin or Ceftriaxone? The dose there is 50 mg per kilo. It is FDA approved for single-dose treatment. It's also FDA approved for 3-dose treatment. That would be IM Q day times either 1 dose or 3 doses. You do have about a 95% cure of 3 doses. It avoids the oral route, so if you have a lot of vomiting, it's quite useful. If nothing else is working, or if you're worried about GI absorption, either patient's got a lot of diarrhea, or patient's short gut, or the patient has malabsorptive issues, it's an excellent choice. Problem is, ceftriaxone given intermuscularly hurts furiously. After the first dose, getting a kid to let you give him the second or third dose is pretty difficult. That is when you mix it with lidocaine. If you don't mix it with lidocaine, the kid will turn around and hit you. And quite honestly, if you haven't mixed it with lidocaine, you deserve it. So mix it with lidocaine. It is useful when nothing else is working, especially if you're contemplating placing PE tubes. Because I've been able to head off more than one set of PE tubes by either using IM Rocephin, and again that's Ceftriaxone, or by using oral clindamycin. Why not jump the clindamycin earlier? Well, it's got a very broad spectrum of action. It has some nasty side effects, including it's highly associated with Clostridium difficile. There's actually only one F in C. diff. And it tears up the gut. It's really hard on the GI tract. Additionally, it's quite expensive. So not, and this is a C, not an E here, just so you know. This is my bad handwriting. So I will use one of these 2 therapies for kids that I'm sending to ENT to place tubes emergently. And, you know, I'll hook them up with ENT, and while we're waiting to get them in a few days, we'll initiate therapy with this. And more than once I've been able to avoid the tubes, at least for a few months. Anyway, that brings us back to here. Realistically, that is all I wanted to say about management of otitis media. That's what you need to know in terms of how to manage the disease. As far as how to diagnose it, you need to have signs and symptoms of a systemic illness. You need to have a red and bulging tympanic membrane. That means, first, you have to see the tympanic membrane. Second, you need to insufflate said tympanic membrane and check it for mobility and see if it is bulging. If you do not use an insufflator, you did not examine that ear. Sometimes you can't see the drum because there's pus pouring out of the drum. That's a different scenario because now you've got OM with perforation, and that's a little more obvious. If you have OM with perforation, let me discourage you from trying to culture that, because unless you are really careful about culturing right from the opening of the tympanic membrane or from the os of the PE tube, you tend to just get ear canal flora. So it's not all that useful to culture. Its biggest role in culturing, or the biggest role of culture, is when absolutely nothing else is working. You've put in tubes, you're still having pus pouring out, and you're getting pretty desperate. It might be able to guide your therapy. Otherwise, it's just gonna give you false leads, and you're really gonna get nowhere and spin your wheels. And the drum's got to be red. I want to emphasize that. You should see pus behind the drum. If you look in and you're like, well, you know, it's kind of red, here's some, it must be here, we need to give you antibiotics. No, it needs to be really red, and it needs to be persistently red. And one way to make sure that it's persistently red is watchful waiting, assuming you're following that portion of the guidelines. Now, I know a lot of people won't wait because part of waiting means you need to be able to trust the family to come back, and you know, with a lot of families you can't trust them to come back, so that being the case, you can't wait for 48 hours because they won't come back for you to recheck them. But with families that you can trust, watchful waiting will avoid a lot of this because you'll look in the second go around and the ear will be better. Roughly 25 to 30% get better on their own in 24 to 48 hours. Anyway, if we can be of assistance here, feel free to give us a call. We would be happy to either see your child for consultation or to see you for a well visit, or to schedule a rotation with you if you're a student. We can be reached at 775-359-7111. This is in the United States. This is in the state of Nevada. Though I am licensed in the state of California, this is where I practice. Have a nice day.